Hi, this is Piyush Bhargava and you're watching the HIDA scan teaching file. HIDA scan or hepatobiliary scintigraphy is performed for several indications, including cholecystitis, both acute and chronic cholecystitis, and to evaluate patients for bile leak. The radiopharmaceutical used is 6 millicuries of technetium-99m mebrafenib, which is injected IV, and immediately after injection of the radiopharmaceutical, we acquire dynamic images of the abdomen in an anterior projection 1 minute per frame for 1 hour. We review those images and decide if any intervention is needed, such as delayed imaging, administering CCK to calculate gallbladder ejection fraction, to do a SPECT CT, or to give morphine. The mechanism of uptake is active uptake, and the radiopharmaceutical is taken up actively into the hepatocytes, just like bilirubin, but at the same time it's not conjugated before it's excreted into the bile. So that's the difference between how hepatocytes treat bilirubin, which is taken up actively, conjugated and excreted, and the radiopharmaceutical, which is taken up actively and excreted without conjugation. Physiologic activity is seen in the liver, biliary tract, bowel, and some excretion is seen from the kidneys into the urinary bladder. The critical organ for this radiopharmaceutical is the colon. Let's look at a normal HIDA scan in a cine mode. So we are looking at 60 images, each acquired 1 minute per frame and played together as a movie. So we see that there is good uptake of the tracer into the liver. The cardiac blood pool activity, which is faintly visualized initially right there, disappears very fast, and then the liver excretes the tracer into the biliary system. We see the activity getting into the gallbladder, and then we see activity going from CBD into the small bowel. So at the end of an hour, we should see prompt uptake and excretion of the radiopharmaceutical from the liver into the biliary tract. We should see activity transiting from the cystic duct into the gallbladder, and the activity should go also from CBD into the small bowel. So those are some of the components of a normal HIDA scan. Here is another way to look at these images. Since these are 1 minute per frame images for 60 minutes, we are looking at the first set of 15, second, third, and the fourth set of 15-minute images. And at the end, we find that most of the activity from the liver has been excreted, and we see it in the small bowel. We see that the cystic duct is patent and the activity is also in the gallbladder. So another example of looking at a normal hepatobiliary scan. Now let's look at an abnormal scan. Here, as we go through the images, we find that this is the cardiac blood pool activity. It disappears within the first 10 minutes, indicating that the hepatocellular function is good. The liver becomes more intense with time. There is excretion of tracer into the small bowel. And as we follow these images, we find that most of the activity is excreted from the liver into the small bowel, but there is no cystic duct activity seen. There is no gallbladder visualized. So at this time, you want to question whether this patient has cystic duct obstruction or acute cholecystitis. And we want to give them either morphine, some more tracer, 1 to 2 millicuries, and acquire additional images for 30 minutes, or the other option is to wait for a few hours, up to 4 hours, and then acquire delayed images to see if the gallbladder lights up. Now in this situation, we gave this patient morphine and acquired post-morphine images, which are seen here, 10 minute, 20 minute, and 30 minutes post-morphine. There is no cystic duct or gallbladder activity, confirming a diagnosis of acute cholecystitis. Case number 3 shows another abnormal hepatobiliary scan with good uptake in the liver, excretion from the CBD into the small bowel, and as we go towards the end, we find that there is activity in the gallbladder. Gallbladder is enlarged and distended, and this is a situation where we want to evaluate them for chronic cholecystitis, give them CCK, and calculate the gallbladder ejection fraction. So these are post-CCK images, and you can see that the gallbladder activity barely changes from the first image to the last image. Here is a dynamic acquisition. The gallbladder activity, like we saw before, does not change. We have drawn a region of interest around the gallbladder. We have marked the background to calculate the time activity curve. Here is the time activity curve showing that the gallbladder ejection fraction was only 9%. which is abnormal, and these findings are consistent with chronic cholecystitis. Here's what a normal gallbladder ejection fraction or emptying would look like in response to CCK. Here we see that the gallbladder was distended to begin with, and when we gave CCK, it contracts promptly, and most of the activity is excreted from the gallbladder into the small bowel. So here's an example of normal ejection of the gallbladder in response to CCK. Case number 4 is showing another abnormal HIDA scan, where as we look at the images, we find that the cardiac blood pool activity persists. The liver takes up the tracer but does not become significantly intense with time. And the same finding is seen in the second, third, and the fourth set of 15-minute images. And at the end, we find that the cardiac blood pool activity persists. There is faint uptake in the liver, but there is no excretion. Now, in this situation, when the liver is not taking up the tracer and the cardiac blood pool activity is persisting for a long time, the diagnosis is hepatocellular dysfunction from either hepatitis or from some other cause. Liver is not taking up the tracer, the hepatocellular function is impaired, and that's the reason why the liver is not able to excrete the tracer. So in this situation, the intervention that we have as an option is to acquire delayed images, and we did a 24-hour delayed image, and we are looking at, on this lower right corner, a right lateral view of the abdomen at the end of 24 hours showing activity in the gallbladder, ruling out acute cholecystitis or cystic duct obstruction. So remember, when the hepatocellular function is impaired, liver may not excrete any tracer, and the only option we have is to give liver some more time to process the tracer, and maybe the delayed images will show some small bowel activity or like we see here, gallbladder activity. Case number 5. This is a cine hepatobiliary scan showing yet another abnormal diagnosis that we a diagnosis that we make on an abnormal hepatobiliary scan, where as we look at the dynamic images, we find that the hepatocellular function is good. The liver takes up the tracer, the cardiac blood pool activity promptly goes away, but the liver does not excrete the tracer. There is no activity in the biliary system, there is no cystic duct or gallbladder activity, and there is no extrahepatic CBD or small bowel activity. The diagnosis here is CBD obstruction, the most common cause being a stone that has been that has moved from the gallbladder into the CBD and is causing CBD obstruction. By the time we scan these patients, the entire hepatobiliary system proximal to the obstruction is filled with non-radioactive bile, and because of that, liver is not able to excrete any radiopharmaceutical into the biliary system. So the distinction here from the case that we saw before is that the hepatocellular function is good. Liver takes up the tracer but is not able to excrete anything because of CBD obstruction. Here is how it would look like when you are looking at the individual images, the 1 minute per frame images acquired for an hour. Look at the first image and look at the last image. The liver takes up the tracer, but there is no excretion. This is also called the liver scan sign, because the liver looks like it would look on a technetium 99M sulfur colloid liver and spleen scan. Case number 6 shows images from an abnormal hepatobiliary scan, where as we go through the images, we find that the hepatocellular uptake is good. There is excretion from the biliary tract into the gallbladder, which we see here. There is no small bowel activity, but the abnormal finding is that in the right lateral surface of the liver, there is a focus of abnormal activity, which is seen here. And as we follow that focus on the surface of the liver, we find that that focus increases in intensity. And on the last image, that focus is seen here. It's outside the liver, and this finding is consistent with a small bile leak which happened after a liver biopsy procedure. Small bile leaks like this can be treated conservatively, and there is no need for any intervention. So here's an example of a small bile leak post liver biopsy. Case number 7 shows a larger and more significant bile leak in a patient who is post-operative. As we go through the images, we find that the abnormal focus appears here in the right upper quadrant at the edge of the hepatic segment 6, and as we follow this activity, it becomes more intense and it enlarges, and the activity even drains in the pattern of the surgical drain, which is seen here. So this is another example of a more significant bile leak. Case number 8. Here we have multiple images from a hepatobiliary scan where we see uptake in the liver, but there is no excretion into the biliary system, small bowel, cystic duct, or the gallbladder. Now these are images from a pediatric patient. Pediatric patients, often when they present with conjugated hyperbilirubinemia, the question is to differentiate between neonatal hepatitis versus biliary atresia, and a hepatobiliary scan comes in very handy, where when we do not see any excretion on the first 1 hour of imaging, we do delayed 24-hour images, which we see here, and on the delayed images, when we do not see any excretion, the findings are consistent with biliary atresia. Case number 9, another interesting hepatobiliary scan as a in a cine mode. The hepatocellular function is good. There is some excretion into the biliary system. We see some CBD activity, but the abnormal finding is seen right here. So the activity goes into the cystic duct and the gallbladder, and then the gallbladder is seen to be communicating with the colon. Here is a transverse colon, and the bile is seen going from the gallbladder into the transverse colon. This is a very rare diagnosis of a cholecystocolonic fistula. More images from the same patient. The coronal image from the CT scan showing the communication between the colon, the hepatic flexure of colon, and some air in the gallbladder. Here on the sagittal image, we see the same finding. There is some air and the communication between the colon and the gallbladder. Patient also had barium enema. A bottom left image is from the barium enema, showing the contrast going into the gallbladder. Case number 10 shows utility of SPECT-CT imaging along with hepatobiliary imaging. On the top, we have images showing excretion of the contrast or the tracer from the liver into the biliary system, CBD, and the small bowel. And the fused SPECT-CT images show a larger fluid-filled collection, which is seen here as a hypodense area. So this patient presented with a large fluid collection, and the question was whether this is a biloma. But looking at the HIDA scan images and the fused SPECT-CT images, we find that the collection is not completely bile. The biliary system is sort of embedded somewhere in this collection and is not communicating with that collection. Case number 11 shows multiple images from a trauma patient with a diagnosis of bile leak, where as we go through the images, we find that there is leakage of bile, which is seen here in the left upper quadrant, which becomes more intense with time, and then it moves more inferiorly into the pelvis. So a large bile leak in a trauma patient. Here is another interesting case, case number 12, a 12-week old male child with conjugated hyperbilirubinemia, and the question was whether they have neonatal hepatitis versus biliary atresia, and the images on the left are from a hepatobiliary scan showing uptake in the liver but no excretion. 24-hour delayed image showed the same finding and trying to sway us towards biliary atresia, but when a ultrasound scan was repeated in this patient, we found that they had these shadowing gallstones, which we see here, and the CBD at the porta was seen and measured about 0.1 cm. So these findings putting together, they were consistent with CBD obstruction secondary to cholelithiasis, which was secondary to prior TPN. So remember, in babies, when they are on total parenteral nutrition, they can develop gallstones, and those gallstones can go down into the cystic duct, cause acute cholecystitis. They can go down into the CBD and cause CBD obstruction, which may look like biliary atresia when you are doing a hepatobiliary scan. So those are some of the patterns that you can encounter while reading HIDA scans or hepatobiliary scintigraphy. Thanks for watching.